Hi, I'm Mark Bailey. I am a pain physician practicing at the University of Alabama at Birmingham, and we're going to talk about controlled substance, mostly opioid prescribing. Just a bit of housekeeping. Almost everybody, every state has got a CME requirement for controlled substances. This one will count for 1 hour of that. Also, DEA has required a one-time 8-hour CME requirement with either use disorder or controlled substances, and this one will count as 1 hour of that as well. I have no disclosures. I don't think I'm going to be talking about anything off-label, but if I do, I'll be sure to say. And I have made every effort to include cultural diversity and elimination of bias in the creation of this presentation. This is my helper, Dr. Simon Bar-Sinister. Those of you old enough to remember Saturday morning cartoons will recall that he was the evil arch nemesis of our hero Underdog in the 60s era cartoon. He is now neurologist, scholar, and patron saint of UAB neurology, so he's going to be helping me out. Overview. We're going to talk about some basics of opioids, sort of pharmacokinetics and basic pharmacy. We're going to talk about their effectiveness both in the acute and chronic setting. We're going to talk about when is the use of opioids appropriate, and that's a rapidly changing answer there. Evolving trends in pain management and prognostications, those are what Bailey thinks is likely to happen in the near future, and my crystal ball is probably no better than anybody else's on that one. That's a tough call. Definitions. Chronic pain is anything for over a month. Acute pain is anything less than a week. Those are pretty standard definitions now. Pretty much everybody agrees with them. There were some discrepancies in the past. A couple of concepts that we need to sort of wrap our heads around when we're talking about pain medicines and prescribing. One is morphine equivalent dosage, and that gets abbreviated all kinds of ways. OMEs, opioid, MEQs. I'll try to remember to say both when I talk about them, but basically it is the currency of pain medicine. It is how much medicine your patient takes per day converted to milligrams of morphine. So, you talk about a patient who's on Norco-10s 3 times a day. Hydrocodone is equianalgesic with morphine, so that would be 30 OMEs, 30 MEQs. That would be less than someone who was taking 30 milligrams of morphine 3 times a day, which would be 90 MEQs. So that's just how we talk about how much medicine your patient is taking, converted to milligrams of morphine. Opioid risk has 2 prongs to it, and it is an assessment that we really need to be making every time we see a patient and writing them pain medicine. First prong is how likely is it that your patient is going to use opioids in a non-prescribed manner or for a non-medical, that is, recreational purpose. It also includes factors that patient health risk might be increased by taking opioids. For example, a little old lady dragging an oxygen bottle would be at a higher risk for respiratory depression than a young, healthier person. So opioid risk sort of encompasses both those terms, and we'll talk about the particulars of documenting those later in the presentation. All right, pain. One tricky thing about pain, and it's not a difficult concept, but it's one that we have to keep in mind, is that there are lots of components to pain. And the example I like to use is, let's say that there was a big football game on television, you're watching it, you've got money on one of the teams, fourth quarter, score is tied, a close game. And now let's say I sneak up on you with a hammer and bop your toe. Well, a lot of things happen. Tissue damage occurs, histamine and all kinds of pro-inflammatory chemicals get released. Neural signals get transduced and sent to the spinal cord. Some processing happens there. The information is sent on up to the brain where most of the processing happens. Lots of areas of the brain involved, but then you perceive pain. And you turn and say and think naughty things about Bailey and his hammer, but then something happens on TV and you're back to the game. Didn't end up being that big a deal at the end of the day. Now let's paint the picture the next day. Your team lost, you lost a bunch of money, you drank too much last night, the weather's bad, your hair's not working this morning. It's a bad day. Now I sneak up on you, same hammer, same toe, same tissue damage occurs, but it hurts a lot worse, right? It's the rest of that stuff going on in there that makes so much difference in the perceived quantity of the pain. So the point of all this long story is that the pain that's experienced is related to the hammer and the toe, but it's not the same thing as the hammer and the toe. Most of the time that's pretty easy to see that relationship, sometimes it's not. Opioid basics, and again Dr. Barcenas is going to help me out here. Opioid taxonomy, and bear with me here, I know you're thinking this is, medical school kind of lecture, but it does have some relevance to us. One way of dividing opioids up into different groups is a synthetic versus semi-synthetic versus natural opioids. Synthetic opioids, you can see the list here: fentanyl, methadone, tapentadol, meperidine, Demerol. The semi-synthetics are probably what most of us are most familiar with using: hydrocodone, oxycodone, hydromorphone, oxymorphone, and buprenorphine. The natural opiates are morphine, codeine is metabolized to morphine, so same thing, and then the endogenous opioids that we produce naturally. The reason, or one reason, this kind of distinction might be important is that, let's say you had a patient on hydrocodone and you had bumped them up and now they're taking 5 times a day and they're still complaining of pain, and you think, okay, well, it's time to change drugs here. I don't really want to go up any higher on this one. It's time to change the pain medicine. I will tell you that you will do much better if you will switch categories rather than switching from, say, hydrocodone to oxycodone, which would be within the semi-synthetic category. Switch it to morphine, a natural. You'll get better results and better pain relief if you do that, and it has to do with cross tolerance and that sort of thing. Pure opioid agonist, these are the star of the show and most of what we're talking about. We used to divide these up into weak and strong. That nomenclature is largely gone. The historically weak ones was tramadol, codeine, and Darvocet is gone now. And then the quote strong ones were the rest of them, really. One opioid agonist that we tend to forget about is loperamide, which is an opioid agonist. The only difference in it and the rest of them is that it does not cross the blood-brain barrier. That is a peripheral-only agent. And so who cares about an opioid that doesn't get into your brain? Well, opioids do a lot of things in lots of parts of the body, but certainly in the gut, they slow and maybe stop peristalsis. And so everybody knows Imodium, what do we give that for, is diarrhea. So that's what happens. It is an opioid agonist that does not cross the blood-brain barrier. The rest of these are our traditional mu agonists that do cross the blood-brain barrier and produce analgesia. Imodium does not produce analgesia. Partial agonists, a little bit trickier. three drugs up here at the top are all agonist-antagonist pairs. These are older drugs. They're not really used all that much anymore. The idea in the creation of these things was that the agonist was going to produce the analgesia, and the antagonist was going to help out with the side effects, the respiratory depression, the constipation, etc. Didn't really work out all that great. Not really used that much anymore. Stadol, I have seen used Stadol nose spray for migraine abortion. That's on its way out. Nubane, I have seen OB doctors use that. I'm not sure what their reasoning is, honestly. Talwin or pentazocine, I haven't seen that written in years. They are partial agonists. Now, buprenorphine at the bottom is also a partial agonist. It's not an agonist-antagonist pair like the other ones. So what is a partial agonist? This is an example of a full versus a partial agonist. This comes from the addiction literature. Methadone is the full agonist, buprenorphine is the partial agonist. The difference here is that with a full agonist, you can pretty much give more drug and get higher drug level in the blood and higher effect, more analgesia. The partial agonist, at some point, you can give all the increased dose you want to. You're not going to get more pain relief. It has a ceiling, and that's one of the characteristics of a partial agonist. Pure antagonist. Well, we know, the Narcan nose spray is the one that we probably know the best. It's a great way to administer an opioid antagonist. It's usually given in the setting of controlled substance. In opioids, I give all my patients that I write opioid prescriptions for a prescription for a Narcan nose spray. It's available over the counter. Obviously, if you write a script for it, then the insurance covers it. Now, this last one here on the list, and I'm not going to try to pronounce those because I probably won't do it right, but it's a higher potency mu antagonist, and it's supposed to be stronger, it's supposed to last longer. I have not used it myself. It is supposed to be a more potent agent in opioid reversal, so we'll see how that one ends up playing out. Now, just like those are centrally acting antagonists, we have peripheral-only antagonists. Relistor and Movantik are the trade names of the drugs, and they are opioid antagonists that do not cross the blood-brain barrier. So they do not antagonize analgesia. If you take an opioid and you take one of these peripheral antagonists, it does not affect your pain relief. What it does do is opioids are mu agonists in the gut, so they shut the gut down, and opioid-induced constipation is often a problem for our patients. Constipation is one of those opioid side effects that does not go away. You don't get used to it. It's dose related, so the higher the dose, the more the constipation. Most of the time this can be taken care of with Miralax, over-the-counter laxatives, etc. Sometimes it can, and if that's the case, these will release the opioid from the opioid receptors in the gut, again without affecting the central nervous system. Now, I have patients that take these. Most of them, the vast majority I would say, we can handle without them. My patients that have them don't like them. They say that they are fierce, that it's like bowel prep kind of fierce. They tell me that yes, it will work, and you better be standing by the bathroom when you take it because it does work. Do not take it and then go to the grocery store. So just fair warning there, but they're pure antagonists. Opioid metabolism. Most opioids are natively active, so they work relieving pain in the form of the drug that you give. There's a couple of our common ones, though. Hydrocodone and tramadol particularly are not natively analgesic. And that's kind of a weird thought that Norco hydrocodone is not analgesic. It's not by itself. It depends on liver metabolism to convert it to hydromorphone, which is the active agent. So if your patient has got bad cirrhosis and doesn't have two P450s to rub together and to convert the hydrocodone to hydromorphone, you might get some conversion at whatever level the patient's functioning at, but you'd probably end up having to use really high doses of hydrocodone to get an effect. So much better than trying to push the dose of hydrocodone in a cirrhosis patient, switch drugs, switch to one of the natively active ones that do not require liver metabolism. And my guess is probably most of us have at least a couple of patients in our practice that have bad livers. And you can extend that as far as you want. I mean, there are people that have, you know, LFT abnormalities and something's going on there. I usually won't switch a patient from hydrocodone to something else if they're stable on the hydrocodone and then suddenly their LFTs start climbing. I usually wait and hear from the patient and see if their pain relief is still okay. If it's not, then I have a pretty short fuse on switching them to one of the natively active agents. Historical perspective. Now you guys have probably all seen this in all these pain presentations. Attention started really focusing on pain and pain relief in the 2000s. The common public perception was that doctors weren't adequately treating pain and that our poor patients were dying in pain and something had to be done. Politically, that was a big outcry. There were lots of things that happened as a result. The Joint Commission gave us the fifth vital sign in the hospital, which we still have, despite most of the major organizations decrying the use of pain as a fifth vital sign. We have a lot of people who have been way over-medicated because of that, because you've all had the experience. Your patient's in the hospital, they're dead asleep, the nurse comes in at midnight and wakes them up and says, "What's your pain?" And they can barely wake up, but they'll say 10 of 10. Okay, well, what has the nurse got to do? She scurries off to the MARs, she looks at the biggest gun that has been written there, and they prescribe and they give it. She has to go wake the patient up again to give them the pain medicine, but it truly wasn't necessary, and that's where the fifth vital sign has really bitten us in the hospital. Not so much a factor outpatient, but in inpatient, that's a big deal. Most of the time, particularly with the full agonist, we think the dose response to opioids is linear. You give more drug, you get more effect, that is analgesia, but at some point you run into unacceptable side effects, just like most other drugs. And back 20 years ago, that's how we handled opioids. The patient says, "Doc, it's not working," you give them more, and you give them more, and you give them more, and eventually either they're, you know, cognitively impaired because of the dose of opioids you're writing, or they hadn't had a bowel movement in 2 weeks because of the dose of opioids you're writing, or somewhere below that they get good analgesia. Well, we don't do that anymore. I don't know that that's malpractice, but it's certainly not, that's not standard of care. Titration of the dose. As a young pain doctor, I was taught that the right way to treat a patient with pain was to give them a big bottle of whatever short-acting agent you were going to treat them with and tell them, "Go home and eat as many of these as you want to. Come back and tell me in a week. We'll see where you're at." Okay, so the patient comes back in a week and says, "Okay, how many did it take?" So, "Well, if I took 10 or 12 a day, I was okay." Well, and then what you were supposed to do is to convert 10 or 12 of whatever milligram pills you were giving them to an extended release version, give them those, and still give them the big bottle of short acting and say, "Okay, take the extended release, here's a big bottle of short actings, take whatever, you know, whatever it takes, and then come back and see me." You see where I'm going with this. The idea was to gradually put everything in the extended release, but to continue the short acting as a breakthrough pain drug. Again, I'm not sure that this is out and out malpractice, but certainly that is not the way anybody that I'm aware of practices these days. It's just, you're getting way too much drug out there in the community. Opioid increased use over the course of 2000 to certainly to 2010 or thereabouts. Doctors responded to this outcry that we were not adequately treating our patients' pain. About that time, some of the pharmaceutical representatives were coming to our office and telling us that opioids are safe, that there's a fairly low percentage of people that get, quote, addicted to them, and I'll talk a little bit more about that later, but so we wrote more medicine. And my next slide will demonstrate some of the side effects there. Well, one of the effects was that in about 2010, the perception was that evil doctors were over-prescribing pain medicine, and we were having people dying left and right of overdoses. Well, okay. In about 2016, the CDC came out with some guidelines on opioid prescribing for primary care doctors. This kind of has its own set of soapboxes to stand on. I'm not going to stay on that one too much, but I will say that a lot of what they put in there was really good, and some of the stuff that they put in there was really bad, and there was some significant blowback from that. A lot of people got their opioids adjusted as a result of the 2016 guidelines that were not done appropriately. So this is arguably the most important slide in this deck. The green, we're starting at 1999 on the left and going through 2017, which is the last I could find of an updated version of this slide. The green area is how much stuff we were writing, how many opioids were written by physicians. Well, as you can see, from 99 to about 2000, we were told that people were dying of pain and that we needed to write more, so we did. That's what happened, and you see the green line going up. You see the overdose deaths, which is the black line there that Dr. Barsinister is indicating. It went up as well, pretty much in parallel, which is about what you'd expect. We wrote more, overdose deaths went up by about the same amount. Well, in about 2010, with the advent of the so-called opioid epidemic, people looked around and said, holy cow, you doctors are writing too much stuff, you're killing people. Okay, so all this new advice on writing pain medicines came out, rules, regulations, guidelines, suggestions. A lot of how to reduce opioids information came out about that time. And so doctors did what they were, that's what we do, that we started writing less pain medicine. And you see the green line start going down after about that point. That's when we started having to get CME for like this, opioid prescribing, et cetera. But there were hoops we had to jump through. Well, so we wrote less stuff. Well, obviously the idea was to help out with the, quote, opioid epidemic. And what we mean by that is overdose deaths. I mean, that's the metric that we're measuring the opioid epidemic by. So we wanted to decrease opioid deaths. Well, so we're writing less medicines, but look at the black line. It did not go parallel to the green line anymore. It shot up out the roof. So lots of reasons for that, and we may talk about some of them, but the bottom line is that all these new regs, guidelines, et cetera, didn't really have the desired effect. We still have got a lot of people dying of overdose. Mostly, I think it is because the drug of choice changed. Instead of something that the physician was writing for you, they couldn't get that, so they're going to the street and they're buying fentanyl and heroin and who knows what strange combinations thereof, but dangerous drugs because they're not who knows what their potency is. So I think that's why we see in the overdose. And I think, let's see, the red one is the synthetic. That, I mean, you see it's climbing up exponentially. That would be fentanyl is the main thing. Here is what opioid prescribing in the U.S. looked like, sort of state by state. Darker colors is more opioids prescribed, and you see in 2010 the South and the Appalachian states were a hotbed of prescribing opioids. 5 years later, that was reduced. 3 years later, still reduced. 2 more years, still reducing. You see the pattern here. Less opioids are being written. Now again, this is prescribed opioids. This is not street fentanyl that we're talking about, because it's still killing people in record numbers. Here's the overdose death by state. Darker colors is higher amounts, and this is 2023. Again, this is the last data I could find that gave these kind of numbers, but you know, this is not population adjusted. It's just how many overdoses in the state. You can look and find your state and see where you're doing. Alabama actually is doing worse this year. Risk of opioid use disorder. This is a hotly contested one. How likely is it that your patient is going to get in trouble with a use disorder if you start them on therapeutic opioids? A hard number to come by, and initially that's what the pharmaceutical companies were telling us, that the risk is very, very low, vanishingly low. And they base that on this little snippet of a public comment in JAMA. No science, just one author's comment, and that was the evidence that they had to tell us that opioids were safe. Not the case. We know that now. It's a difficult quantity to stick a number on, probably somewhere between 10 and 30%. And that's huge. That means between 10 and 30% of the patients that we start on a pain medicine are going to develop a use disorder. There's not many medicines, and that's a significant and serious side effect. Not many new meds or even old meds carry that degree of risk of harm that we still have on the market. Opioids potentially can cause great harm. Benzos and opioids, this is a hot button item, largely from a regulatory and scrutiny standpoint. Benzos are respiratory depressants, opioids are respiratory depressants. Taken together, they can produce marked respiratory depression. That's true. It is, and if your patients are on chronic benzos, trying to find a non-benzo alternative is the right thing to do. Your patients, if you go to the PDMP and get the report on yourself, and that happens, that's sent to you twice a year, I think, but you will see how many of your patients are taking opioids, how many of them are taking benzos, how many of them are taking both, and how many of the benzos that you're writing the opioids for, how many of the benzos are written by you, and how many of them are written by others. I mean, those kind of metrics are being kept on all of us, continuously. Now, when the PDMP first came out, the regulatory folks promised us that this was not going to be a forensic tool, that they weren't going to be surfing the PDMP looking for top prescribers and scrutinizing them more carefully. Obviously that's what has happened. I don't know if that was their intent or not, but it is. I guarantee you that the folks at the state board know what are you in the top 5% of prescribers. Do you prescribe a lot of benzos with your opioids? Because they're looking at that, and if they look at it, hopefully it won't cause you any problems, but best to stick away from that one if you possibly can. The pain fellows at the university have journal club at my house once a year, and we usually invite somebody from the state board to come talk to us and kind of give us the board perspective on what they're what they're thinking, what they're looking for. This comes up way at the top of the list. These guys are obviously looking for this. Now, it doesn't mean that your patients can't take benzos, but you better have documented in the chart that you tried everything else and it produced inadequate quality of life or et cetera. You can, but you just got to document carefully that that benzos are required along with the opiate. Fentanyl, we're not talking about your grandmother's fentanyl patch here anymore. We're talking about kilo blocks of stuff coming up from South America, from overseas. High potency agent. My anesthesia brethren can tell you exactly what the conversion is from micrograms of fentanyl to milligrams of morphine for OMEs, but fentanyl is a high potency agent. This slide I borrowed from a Homeland Security agent whose concern was not so much the overdose death rate. He was worried that when his agents were going through the stuff coming into the US and finding these white plastic wrap blocks, if they grabbed one and there was a pinhole in it, could enough stuff whiff out to harm the agent? Well, there's a penny. There is a potentially lethal dose of fentanyl. So I think it goes without saying that yes, enough could whiff out. You got it in your eyes, you inhaled when it hit you in the face, you had abrasions on your hands, etc. It is a high potency agent. So just to put that in some perspective. Gabapentin, you know, I used to be a for real neurologist, and we used a lot of gabapentin for all kinds of things, some of it pain related, probably most of it pain related. But we were pretty free with it because we were told that it has no known drug interactions, excreted unchanged by kidneys, so you don't have to worry about, you know, liver compromise, etc. Well, and then we found a drug interaction, and it's with opiates. Respiratory depression combining opiates and gabapentin is a big deal. Like it says there, nearly 60% increase in the risk of opioid-related deaths. Now that's dose-related. Lower doses of gabapentin, lower doses of opioids, less risk of respiratory depression. Doesn't mean you can't write gabapentin for your chronic pain patients who are also on opioids, but it is definitely a risk factor that you need to account for when you're thinking about opiate risk. The higher the dose, the more dangerous it is. And here's unintentional overdose, the blue line, and at the bottom you see the dose ranges. But I mean, the bottom line is that the more opiate you give, the more likely it is you're going to get overdosed. Suicide is the red line at the bottom, and that also seems to be dose related. I don't think that surprises anybody. But one thing that you probably at least need to be aware of here is that there is no sudden point in the dosage that the risk skyrockets. You know, it's not like below 50, it's, you know, not too bad, and then over 50, they're dropping like flies. That's not the case. The response is fairly linear. Opioid effectiveness. Morphine works. And we all know that. You break your leg, you're in the emergency room, the ortho guys come in and do whatever they're going to do. Morphine works. It will help with the pain. Acute pain. No problem there. The problem comes in the chronic pain setting, which is where opioids are given long term, and then you start running into side effects versus benefits. We don't have a lot of science here to really help us. We think that the long-term benefit of opioids is something about 30%. And I think I've got that on another slide somewhere, but it's not much. I mean, it's not nearly what we would hope it is, particularly with your patients who have been on, you know, they've got a crummy back and they've been on Norco 10s 3 times a day for most of their adult life. how much benefit they're getting from that is probably not much, not from a pure opioid analgesic standpoint. Current practices. When to prescribe opioids in current practice. Now that's a big one. That's a judgment call. It's you know, in days gone by, a 50-something-year-old guy that had some arthritis in his back gets himself all stove up, doing more than he ought to perhaps. He could come to his doc, and the doc would probably prescribe him some muscle relaxers and some opiates. And you know, next time he got stove up, he'd do the same thing, and the doc would write him some opiates. Maybe he's not taking them round the clock all day, every day, but maybe he ends up evolving to that point that he's taking them every day, and then the doc's starting to get uncomfortable. Well, currently, one of the cardinal rules that I preach to my pain fellows is that you got to have something wrong with you. And in the case of a 50-year-old, 50-something with a bad back, you need imaging of his back. You need to examine him and see, does it seem radicular, does it seem myofascial, et cetera, et cetera. Arthritic, lots of reasons that the back might be hurting. But when you look at the imaging, a little bit of arthritis in the back is not going to justify opiates in this day and age. And that comes as a shock to a lot of physicians and to a lot of patients who've been prescribed them for their adult life. And so, well, what's wrong with your back? Well, I got this, and a chiropractor showed me a slip discus and on an x-ray, and it's okay, well, so we image the back and there's a little bit of arthritis and that's it. I don't write them opiates. I mean, that's just not the right thing to do. There's other things they need to do, and we'll talk about some of that. Jumping through the hoops, and this is where some of our regulatory and guideline elements start coming in. How much opiates, immediate release versus extended release? Almost all the guidelines recommend starting with low dose immediate release and then increasing as necessary, and if end of dose failure happens with the short actings, then converting them to a long acting. That's kind of where we're at right now, but starting with low doses of the immediate release is what's recommended most of the time. How often for office visit as a pain doc, and that's what I do for a living. I'm a pain doc. I see almost all my patients monthly. So once a month, I write them a 1-month prescription for their pain medicine. Now, virtual telemedicine has helped out a lot with this because my patients don't have to come to the office for a lot of those visits. So it's a little less onerous than it might sound. Now, I have a handful of people who I see at 3-month intervals, and they're the ones that I can put refills on their meds. Tramadol patients, gabapentin patients, Tylenol 3 and 4 with codeine, something you can put refills on. I'll put 2 refills and see them in 3 months. But I don't have a lot of those, which is appropriate. I mean, you don't, if you're on T3 with codeine, you probably don't need to be seeing the pain doctor. I mean, your primary care can handle that for you. Documentation requirements, those are, you know, the state board has got lots of recommendations on what is required for documentation. You know, how much does your pain medicines relieve your pain on a monthly basis, the OMEs that your patient is taking, when did they take their last dose, when was their last drug screen, et cetera. That's the kind of stuff that you want to be documenting. Risk stratification, we're going to look at some examples here in a minute, but mostly that's done by low, medium, or high risk. And that's got to do with lots of things. It's got to do with the dose of opioids. It's got to do with other medical comorbidities, the little old lady dragging the oxygen bottle, for example. But so who cares? Well, I mean, what if you label somebody as high risk versus low risk? I use that to decide how often to drug screen them. Low risk patients I drug screen once a year. High risk patients I drug screen 4 times a year. Medium risk I drug screen twice a year. That's what That's what Bailey does with that information. Dose reduction can be dangerous, and I've got a slide on that. And when that really came to bear was in 2016 when the CDC guidelines came out. A lot of docs just said, I'm not writing this much stuff. You don't need this much stuff, or I'm not writing it, see ya. And a lot of people cold turkeyed, a lot of people got their dose cut way, way back. And a lot of them committed suicide, and a lot of them did really bad from lots of perspectives. Opioid withdrawal is not medically dangerous most of the time. I mean, if you've got a sick person and you cut them off from medium to high doses of opiates to nothing, maybe withdrawals is medically dangerous to them, but not natively so. Benzos is different. I mean, seizing and dying is a very real risk with benzos if you just stop them. It's not pleasant, obviously. Opioid withdrawal feels like the flu. Aches, sweats, diarrhea, feels like the flu. Recommended non-medication treatments are often not covered by insurance, and there's a list of them there: cognitive behavioral, yoga, tai chi, acupuncture, meditation. All of those have got good science behind them. Often our carriers will not cover them, and that's just awful. I mean, that's our people who are telling us, you evil doctors need to quit writing so much stuff and killing all these people. Well, fine. Pay for Tai Chi classes then. How about that? Oh, never mind, there's good science behind all of that stuff. Cognitive behavioral, excellent science there, but they're not going to pay for it. So that's, they'll pay for morphine, you know, they'll pay for the opiates by and large. They're not one of the new expensive ones, that is. But that's a big disconnect with what we're being told in this day and age and what is the reality, because the reality is if your patient's not covered for whatever you're advising them, then effectively they can't get it. They can't afford it out of pocket. Okay, here's one of the studies I was talking about that compared opioid tapering or abrupt discontinuation versus no dosage change, and you see the findings there in the second bullet point. Do not support opioid dosage tapering as a strategy to reduce harm for those who are stable. I mean, that's the bottom line there. If somebody else from some out-of-state pain clinic has got them on what seems to you to be awfully high doses of pain medicine, and this happens every now and again, you can try to reduce the dose a little bit, but mostly you're kind of stuck with it, and more than you being stuck with it, the patient is stuck with it because they're at high risk. Less pain meds available. This is the absolute bane of my office staff existence right now. Patients that I write a script for, they go to Walgreens and they're told, well, we don't have your medicine, or we only got 10 pills of what your doctor wrote you. Well, so what's the patient supposed to do? We counsel them extensively to not take partial fills at the drugstore, to give us a call, or to start calling around and finding a drugstore that's got their pills. And if they identify that drugstore, let us know, and we will cancel their original script and electronically transmit the new one to the drugstore, the new drugstore. Again, no guarantee, because a lot of my patients have told me they call their drugstore and they say, yeah, we got it. And then when the patient gets there, they say, no, we sold out. I ain't got them anymore. I don't know how many other meds that we're requiring our patients to chase them down in the wild, as it were. I mean, that just seems ludicrous to me, and it seems wrong, but that's where we're at. Well, why are these drugstores not carrying this stuff if our patients require it? Lots of possible reasons, and just to cut to the chase, I'm not going to go through all this stuff because I don't think any of that's the real reason. I think this is the real reason. There's less pain meds available to them. The distributors, the ones that sell the pills to the pharmacy, have gotten their backsides handed to them legally. Huge settlements, $21 billion and 3 large drug distributors. So the settlement that they reached said that, okay, well, we'll, saying that they were involved with the opioid epidemic and killing people and so forth. I said, okay, well, we'll cap the amount of pain medicines that we're going to send to our drugstores. And if they start asking for more than that, we may just cut them off altogether. So when your patient goes to the drugstore and hands them the script, or the script's sent electronically, they might get told, we don't have it, we don't know when we're going to get it, maybe we'll get some next week, we don't know. Well, your patient runs out of meds tomorrow, so he or she is the one that's really up a creek. Here's just February of this year, a drug distributor, I think this one was in Louisiana, huge settlement over opioid sales. And again, this is selling to the drugstores. This was a graphic that I left it in there. I started to take this out, but this concerns telemedicine and prescribing opioids. Can you electronically prescribe opioids to your patient? Well, if it's your patient, the answer is almost always yes. You need to have seen them face to face over, in different situations here, different amounts of time, but if you've seen them face to face in the last 6 months, the answer is yes, you can. Now, if you've never laid eyes on them, it's possible you could write them a month's worth if the referring doc has seen them in the recent past. Referring doc saw them in the office, referred them to you. You could electronically prescribe controlled substances in that situation. Personally, I don't do it. I'm not writing opioids for a patient I've never physically laid eyes on or examined. I just don't feel like that's good medicine. New safety warnings, this is just kind of an FYI. There's black box warnings that are in the package inserts now, and the FDA is bumping those up to include something to be said about opioid-induced hyperalgesia, as well as risk of respiratory depression. That's also in what the patients are reading now. So which pain pill, or what pills work? And I did this kind of as a joke to start off with, and just see what works as far as pain goes, and I just picked low back pain, non-specific low back pain as the prototype here. I thought there'd be lots of information on non-specific low back pain, and there is. So here's comparing medications. Opioids will work. They are our strongest analgesics, and they will work, but it's not long-lasting. And long-term, you get about 30% improvement in your pain levels. People don't get this, and they won't. You really have to explain it to them carefully. If a patient comes into your office and is taking 3 Norco-10s a day, I just wish I had another one, doc. If I had another one, I could take it at night and I could get some sleep. Their pain is 9 of 10. That's what they're reporting. What is going to happen is if you increase the pain medicine, the next visit, the next month, maybe their pain goes down to 7 or 8 of 10, but I guarantee you in 3 months their pain reporting will be exactly what it was before you increase the dose. And now you've got your patient on a higher dose, more risk, etc. Long term, more will not help more, and people don't get that, and maybe they can't, I don't know, but I do the same set of words here to my patients that want more. It won't help. I know you think that you would do better if you had more. You won't. You need to lose weight, you need to exercise, you need to find an online Tai Chi class or a yoga class. And of course, when you start talking about stuff like that, you can just see the barrier drop down. They don't want to hear that. They wanted more pills, different pills, better pills. They don't want to hear about yoga and Tai Chi. Strangely enough, and I don't have a suggestion as far as what yoga class or what Tai Chi class. None of them are paid for. I mean, that's true. None of them are paid for, unless you're at the VA. And those rascals have got incredible tools available to them. They've got mindfulness, they've got acupuncture, they've got all this sort of complementary and alternative stuff available to them as in the VA pain clinics. And when I heard that, I thought, well, good luck in getting one of these old rascals that's had back pain forever and has been on Soma, Xanax, and Lortab for his whole life. Good luck in getting him to go to a yoga class. My comrade who's at the VA says, no, they love it. They go to these things, we're able to cut back on their pain meds, just like it's supposed to be, that you found something that helps them that's not an opiate. But I'm jealous. I don't have that available to me. So there, opioids, they will work, probably about 30% in the long term. More is not better. Anticonvulsants, moderate to high quality evidence that they're not effective in the treatment of low back pain. And I know what you're thinking, that, well, what about lumbar radiculitis? You know, that's a neuropathic pain. Wouldn't gabapentin or gabapentinoid or any other anticonvulsant, wouldn't that help with a nerve-related pain? Glad you asked, because that was studied specifically, and they don't. Gabapentin does not help with low back pain, a radicular low back pain. So no support for gabapentin analgesia. Got a lot of patients with bad backs that are on gabapentin, and we don't have much science to support that one either. Antidepressants, typically it's the SNRIs we're talking about, Cymbalta, et cetera. Sometimes the effects are tricyclics. Mostly we use tricyclics for side effects, you know, sleeping pill essentially. There is low quality evidence that they help some, but it's not much. So if you're looking for that Cymbalta to turn your back pain patient around, might help, probably not going to be the answer. And there are, of course, side effects with SNRIs. Muscle relaxers, they can help. They have side effects also, and often we use those side effects. People gripe all the time. I mean, in my clinic, doc, it's these spasms, you know, that's what's getting me. I can't sleep because of my back spasms. I need a muscle relaxer. Muscle relaxers, well, except for one, do not act at the level of muscle. We have no evidence that shows Flexeril, Robaxin, pick your muscle relaxer, works on skeletal muscle. They're centrally acting. They slow your head down. That's what they do. They don't work at the level of muscle. Now what else will slow you? Jack Daniels will slow your head down, but we don't think of it as a muscle relaxer. There are some people who get lots of benefit from muscle relaxers, and so they're still out there and they're still being used. The one that does affect human muscle is dantrolene. The anesthesiologists use that for malignant hyperthermia. Some PM&R docs write dantrolene. Usually it's in the setting of someone with a baclofen pump and spinal cord injuries and man-eating spasticity that nothing is managing. I don't do it myself. I'm just not, I'm not trained in the use of dantrolene. So muscle relaxers can help with nonspecific low back pain. Nonsteroidals, they can help. Everybody knows the side effects of nonsteroidals, particularly in the older population, GI issues, renal issues. Don't need to go over that stuff, but it's, they do help, or they can help. Multimodal pain treatment. This is the darling of pain management. This has the best track record of any of it in helping people with their back pain. So that means when you go see the doctor, you see the medical doc that's writing your pain medicines, you're seeing the PT, you're seeing the psychologist, you're seeing the counselor, you're seeing everybody at that visit, and they're all coming up with a treatment plan and going over it with you about how they're going to implement it. Multimodal, that's the best. Nobody's paying for it. I guarantee you that they're not paying for it. The only places that can do this are like subsidized places, the big universities that have got a lot of funds coming in to pay these providers for this multimodal visit. But absolutely, science is there that this is the best way. It's a money where your mouth is situation, unfortunately. Pain management trends. Pills are not the trend. And exercise, acupuncture, yoga, tai chi, manipulation, all of these things have got good track records, and that's where we need to be putting our emphasis. So your chronic pain patient that's on 3 Norcos a day is, well, it's just not doing as good as it used to, and I think I need another one. No, that won't help when we do that spiel. Well, what are you going to give me? That's the question. What are you going to give me? I'm going to advise that you lose 50 pounds, that you exercise daily, particularly pool exercise is good because that gets gravity off of your back and get your heart rate up. I'm going to advise that you look into like an online chair yoga class. Those are the kinds of things that will help, and you're asking me, what can I do? What can I do if I'm not satisfied with where I'm at now? Those are the kinds of things. Again, the curtain has already come down. They don't want to hear that stuff. They just want another pill. Again, I'm not going to get on this soapbox too much, but our patients don't seem to be very interested in taking ownership of their own health care. They just want you to give them another pill. Prognostications. This is Bailey. This is not science anymore. This is Bailey's opinion. Opioids are going to have to be viewed as a treatment of last resort when everything else has failed, and you have documented that it's failed, and you have evidence in the chart of the abnormality. Then you can, and the abnormality is bad enough to justify opioids in your medical opinion. Then you could consider the use of opioids, but they've got to be bumped way down the list. There are a lot of folks who are saying that when somebody overdoes it, and they come, hobbling into the doctor's office, and they took the Christmas stuff out of the attic yesterday, and now they can't hardly stand up, that reaching for the script pad may not be the right answer. PT, physical modalities, that's probably the correct answer rather than a medicine. We're not there yet, and docs are going to have to buy into this, and patients are going to have to buy into this, because right now they hadn't bought into it, and it takes considerable coaching to get them to even partially buy into it. This whole pill for every symptom mentality that both docs and patients have. And it's so much easier to write the pill, right? I mean, a 300-pound patient whose knees are shot, whose hips are shot, maybe their low back is going, needs to lose weight. That's the number one treatment that needs to happen for their health. I don't have to tell anybody what happens when you tell somebody they've got to lose, well, I can't lose weight. I only eat lettuce, I only drink water, and I gain 20 pounds, and I can't exercise. Well, you're in luck. Exercise is not really the big deal in weight loss. It's what you eat. And like I said, there's lots of excuses that you will hear why they can't do whatever it is you're advising them, and really all they can do is eat another pill. Patients are going to have to be more active participants in their own health care. That's just going to have to happen if we're going to get away from all these pain meds out there. Our present strategies for dealing with the opioid crisis is not reducing overdose deaths. That's continuing to escalate. So what we're doing now is not solving the problem that we set out to solve. So in summary, chronic pain is widespread, it's an extensive problem, it is expensive problem. There's lots of rules, regs, guidelines. A lot of docs just don't want to do this. I mean, if you need some of that, you need to go see the pain doctor. I'm not writing your pain meds. The role of non-pharmacologic treatment is going to have to increase. You've heard me preach about that one. The opioids are last resort mentality is something that physicians are going to have to adopt, and that's a tough one. This weird looking thing here is a pangolin. I saw him on a Nat Geo special. I just love the way they hold their little front legs up when they walk around. These are anteater-ish creatures. They're endangered. Their scales are used in some traditional medicines. They've got no teeth. I mean, you kick one and he rolls up in a ball and you throw him in the sack. They're Asia, they're African, bunch of different species of it. But, you know, you're feeling philanthropic. Google Save the Pangolins, send them $1, get the t-shirt. That's what I did. This is my contact information. Anybody wants to contact me by way of office, email, my website. Glad to try to field questions for you. And I thank you much for your kind attention.